Hey everyone, welcome to This Explainer. Look, if you're gearing up for that NSG 331 Week 4 quiz covering chapters 13, 15, and 16, you are in the exact right place. Let's just jump right into it. Today, we're going through a high-yield study guide based on Dr. Coy Kendall's lectures. We're going to break down all the complexities of sleep, safety, and aging together so you can walk into that quiz feeling absolutely confident. To kind of ground all this textbook stuff in the real world, I want you to meet George. He's a 73-year-old retired guy with a pretty complex medical history. He recently had an MI, he battles obstructive sleep apnea, and he's taking a whole cocktail of meds to help him sleep. We're talking melatonin, diphenhydramine, and clonidine. And he actually takes that clonidine at night specifically because it makes him drowsy. Keep George in the back of your mind as we go through this, because real-world nursing is all about applying these concepts to actual patients just like him. So here's our game plan for today. We'll cover aging and sleep changes, managing common sleep disorders, priority nursing actions, safety measures in sleep, and then we'll wrap up with some quiz prep practice questions. All right, part 1, aging and sleep changes. You know, it's actually pretty fascinating how much our sleep architecture just physically shifts as we get older. It's not just that older adults sleep less. The actual quality of that sleep changes entirely. Basically, the amplitude of all those endogenous circadian responses naturally drops. This means an older adult's internal clock is just, well, less responsive. They experience way more near awakenings, they're probably going to nap more during the day, and unfortunately, they often wake up feeling totally unrested. It's also completely normal baseline aging to see an increase in abnormal breathing events and leg movements.
Moving right along to section 2, managing common sleep disorders.
Okay, you absolutely need to lock in these big 3 sleep disorders for the quiz. First up, insomnia. For a true clinical diagnosis, a patient has to have difficulty falling asleep for at least 1 month, and, this is key, it must actively impair their daytime functioning. Next is sleep apnea. You're looking for fragmented sleep, gasping, and loud choking. And finally, REM sleep behavior disorder. Think about it. In a healthy person, your muscles are essentially paralyzed during REM sleep so you don't act out your dreams, right? Well, in older adults with this disorder, they lose that normal muscle atonia, which leads to some pretty violent behaviors while they're sleeping. Let's zero in on sleep apnea for a second. You gotta know the stop-bang assessment tool. As a nurse, this is essentially your best friend for identifying a patient's risk level. It looks at factors like snoring, tiredness, observed breathing cessation, and blood pressure. That's the stop part. Then the bang part assesses BMI, age, neck circumference, and gender. If they score a 5 or more, bam, that puts your patient at a super high risk for obstructive sleep apnea. So if your patient actually has sleep apnea, what's the game plan? Well, the medical gold standard is CPAP, continuous positive airway pressure at bedtime. But your nursing education has to go beyond just the machine. You need to advise them to lose weight, stop smoking, avoid alcohol and sedatives, and this is a big one. Avoid supine sleeping. Literally, tell them not to sleep flat on their backs. Section 3, priority nursing actions. Here is a massive, absolutely crucial takeaway for your quiz. Non-pharmacologic treatment is always your first-line approach. Always. Before anyone even thinks about reaching for sedative hypnotics, which, let's face it, are incredibly risky for older adults, we have to implement cognitive behavioral therapy and strict sleep hygiene. A highly testable point here is the 10-minute rule. If a patient is tossing and turning and can't fall asleep after 10 minutes, they need to physically get out of bed, go to another room, stay up until they actually feel sleepy, and only then go back to bed. We actually have a massive toolkit for sleep hygiene. We want to teach our patients to keep a super consistent schedule, even on the weekends. They absolutely must limit caffeine late in the day, and hey, remind them that includes tea, cola, and chocolate. Suggest a warm bath, make sure they empty their bladder right before bed, and firmly advise against staring at electronic devices before sleep. It's all about optimizing their environment to set them up for success. All right, on to section 4, safety measures in sleep. Okay, remember that REM sleep behavior disorder we talked about a minute ago? Because they lose that natural muscle paralysis, they're at a super high risk of literally acting out their dreams. This can lead to severe injury to themselves or whoever is sharing their bed. Now, while the pharmacological treatment is typically clonazepam, your priority as the nurse is entirely focused on safety. We have to educate the patient and their family on modifying the physical sleep environment so nobody gets hurt during these episodes.
And hey, speaking of safety, let's talk about the elephant in the room, restraints. The source material doesn't mince words here. Physical restraints do not protect patients, period. They cause fear, they cause massive agitation, and they can literally lead to serious injury or death. And don't forget, even throwing up a half or quarter-length side rail to keep someone in bed, that is considered a restraint. Restraint-free care is the absolute standard of practice. It's basically the core indicator of whether or not you're providing quality nursing care. So, if restraints are off the table, how do we actually keep our restless patients safe? We go all in on fall prevention. Keep that bed in the lowest possible position. Honestly, put the mattress right on the floor if you have to. Hook up those bed and chair alarms. Bring a bedside commode right into the room so they aren't sprinting to the bathroom in the dark. And always, always do thorough medication reviews because, as we know, polypharmacy is a massive contributor to fall risks.
Let's bring it home with Section 5, Quiz Prep, Practice Questions. Okay, question 1. Imagine a resident in a long-term care facility tells you they just can't sleep. What action would be an absolute priority for you, the nurse, to implement? Think back to what we just said about first-line treatments. Did you guess it? The priority is to decrease the noise around them at bedtime and during the night. Why? Because environmental modifications and sleep hygiene will always, always beat out administering sleeping meds. Those meds carry huge risks for older adults. You gotta fix the environment first. Moving on to question 2. Your patient gets referred for polysomnography, a sleep study, to confirm a diagnosis of sleep apnea. What symptoms would you expect them to report? The answer we're looking for is loud, periodic snoring with choking when they wake up. Bam! Right back to our STOP bang criteria. Fragmented sleep, loud snoring, gasping for air, those are the classic hallmarks of obstructive sleep apnea. All right, question 3. This one pulls from Chapter 16 on safety and temperature regulation. Which patient assessment data does the nurse recognize could contribute to an older adult's risk of hyperthermia? And the culprit is taking furosemide 40 milligrams daily. Let's break down the logic here, because you'll need this for the quiz. Older adults already have decreased sweat gland function, just as a baseline. If they're also taking a diuretic, like furosemide, it lowers their fluid volume even more. That drastically reduces their ability to sweat and cool down, which skyrockets their risk of hyperthermia in a warm environment. As we start wrapping up, I really want this specific quote from the text to stick with you. Restraint-free care is the standard of practice and an indicator of quality care. This single philosophy should literally underpin every single intervention we make regarding patient safety and sleep behavior. We protect our patients by optimizing their environment, not by tying them down. Finally, let's circle back to our guide, George. Knowing his history of OSA, his recent heart attack, and the fact that he takes a blood pressure medication at night just to make himself drowsy, how are you going to individualize his sleep and safety plan tonight? Think about the CPAP, think about that med review, think about his fall risks. I highly encourage you to quickly write out a mini care plan for George as a final study exercise right after this. You've got this. Good luck on the week 4 quiz. We are going to do great.